Hi everyone. Can you hear me okay? Brilliant. Okay, so I hope you've been having a good day at the conference so far. I know I have. And from the sessions that I've been to, there's been plenty of lively discussion, and some of it's been quite wide-ranging about the challenges that we're facing across evaluation in health and social care as a whole, particularly in relation to new technologies. And hopefully it won't stop there. So I'm Johnny Clarke. I'm a Principal Data Analyst in the Improvement Analytics Unit at the Health Foundation, and I'm hopefully going to be helping steer an interesting conversation with our two conversants today, so Dr. Leah Ali and Charles Tallack, and I'll allow them to introduce themselves in due course. But I think the aim of today's session is to try and bring together some of the themes that have been raised over the course of the conference so far, but then to start thinking a little bit more about what the future might hold for these things too. And so what I'd like to do to try and bring that to a start is to hear first from Leah, and then secondly from Charles, some reflections about the conference so far and their priorities, but then also thinking about what the future might hold for those technologies. And then we'll open things up after a period of conversation between the two of them towards some questions that you might have that have been burning and building up over the course of the day. So with that, I'll hand over to you, Leah.
Thank you very much for inviting me. It's been such a pleasure. I've really enjoyed today and meeting many of you. So my name's Leah Ali. I'm a consultant neuropsychiatrist. I still practice clinically in the South London Maudsley Hospital. And I'm also a clinical advisor in healthcare and design in NHS England. And I have quite an unusual background, having been in industry, frontline in the NHS, and now working in the centre. And my things that I'm really passionate about are holistic models of care, so particularly a biopsychosocial model of care, and thinking about how you get services that are truly patient-centred. And I've done that in lots of different ways, in research, in building end-to-end systems, all sorts of different things. And currently in NHS England, I have the NHS App Senior Leadership Team in my portfolio, the Shared Care Record Programme, and also a digital innovation team which looks at digital therapeutics, particularly in the national channels. I think for me, do you want to talk about my future reflections?
Yeah, go ahead. Yeah.
I mean, I just loved the conversations today. Like right from the outset, the opening session, there were so many things that the panel were talking about which really resonated with my experience across all those different domains. I've spent my clinical life trying to get services to line up around the patient. For me, the issue we have is that we have a highly medicalised Western paternalistic system, which is very transactional. We do a thing to the patient, and it's very much focused on the medical model. And actually, that's not what people's health experience is. People's health experience goes across all of that. There's biological, psychological, and social domains. And in every service that I've been involved with, including thinking about how those services are evaluated, complexity has been the absolute norm and the absolute key to understanding how you do something and then also how you improve and iterate it. And I've heard that coming out in every single session today. How do we deal with this level of complexity? I think there's something peculiar about digital and technology that brings that to the fore. It's there in all the healthcare services that we deliver. I was thinking of, in one of the workshops at lunchtime, Fraser was talking about transactional versus relational. So that means two different things to me, but overlapping. There's the way Fraser was talking about it in terms of that interaction. But in the design world, that actually relates to design patterns. So you have transactional design patterns and you have relational design patterns. Relational design patterns are actually what needed to be pioneered in order to allow AI chatbots to be developed. You had to think of a completely different way that the technology had to be architected and organised in order to allow that relational pattern to operate. And that's a lot of what I get asked to consult about in industry outside health as well as inside health. And tackling that and understanding your role as the evaluators, I think is super keen. And I've said to both Johnny and Charlie, the thing that I'm going to keep saying today is that I think you need a voice earlier, and I think you need to be being clear about what you know about what that complex landscape looks like and how you need to plan for how you're going to want to evaluate. I think we often make the assumption, because we're used to evaluating drugs, and I've been involved in randomized controlled trials and all the rest of it. that assumption is not there when you're talking about digital technologies. It's somehow completely different. And there's a lot that we can borrow from digital methods and the way that that's done in industry, but we also mustn't lose what we already know about dealing with health outcomes, dealing with complexity.
Thank you. Excellent. Very good start. So I'm Charles Tallack. I'm Director of Research and Analysis at the Health Foundation. And just a bit about, I guess, my background in evaluation. So I guess my first foray into evaluation in my career was when I joined NHS England in 2016. On the back of the 5-year forward view, I became head of evaluation and operational research, which might seem like an odd combination, the sort of modelling and evaluation side, but one of the things I actually probably want to talk about today is about bringing together different disciplines, because I feel that that's what we need in this space, because it is so complex. One discipline, one way of thinking itself probably isn't going to provide the kind of answers in the complexity. So when I was there, one of the things we did was evaluate. Lots of times we were evaluating big national programs, but we also looked at Babylon GP at Hand, which most of you will remember as being a kind of a bit of a startup in the primary care world and a disruptor. Indeed, they saw themselves as that was one of the things they really wanted to do. So that was very, very interesting, working with a technology company, trying to work, well, firstly, trying to get data from them, which took longer because they sometimes were reluctant to give data, but then looking at the different experiences, including of the people who were employed by them as GPs, working from home, what was their experience? How did they deal with patients compared to a GP sitting in a surgery? So lots of really interesting things, and of course that was before, we now have like widespread online consultations. That was before that, so that was a very interesting time. And then at the Health Foundation, we've got people will have heard of it probably, our Value Improvement Analytics Unit, which was set up around 2016, which we really were trying to get into this rapid cycle evaluation world, and which is now, I think, widely acknowledged as being very, very important, that we need rapid evaluation. Someone spoke to me today about what rapid means, and I said, don't answer that question, because in rapid, lots of the places that are set up have probably spent a lot of time debating what rapid is. To me, rapid is about kind of being aware of what decisions are being made and timing your evaluation to fit those decisions, because those decisions are often the things which there's not that much scope around those. People want to make a decision, they need to make a decision at a particular time. So tailoring your evaluation to that. Generally, the longer you do an evaluation for, the more you narrow your uncertainty. But I think that's something which we all have to accept, that actually some analysis is always better than no analysis, and even though you can't be certain, you can still help give decision makers confidence. Even if you said it's 80% certain that it will have this effect, that at least gives them something to go on and they can make a decision about that. So the other thing just reflecting on today is I think it's really helpful having this as a theme for this conference. It's clear technology, digital technologies are clearly a very big thing for the government. People look to these as being a way of helping the NHS improve, to transform, to become more efficient. But of course, we're talking about lots of different kinds of technologies. There's this sort of digital therapeutics, which I know, Leah, aren't the same as drugs, but they, in some ways, are more similar. There are some similarities, as in they are, people can prescribe these things to patients. How they interact with patients, there's many more complexities, but in some ways, they've got some similarities. But then, of course, there are, diagnostic, technology in diagnostics, all of that stuff, which obviously is used by clinicians rather than patients themselves. They're not the direct consumers of it. But then, of course, there are a whole bunch of non-clinical uses of technology. So all the stuff we see around digital scribes, the sort of note-taking as well, that's really very, very fundamental changes to service pathways and requires often a rethink of how a particular service path could work. So different types of technologies, but also there are different roles for evaluators in all of this. So, there is at a very early stage, and probably where most of us wouldn't be involved is, developers will have evaluators. They'll often have a simulated environment. They'll be particularly looking at safety. They'll be looking at how users respond or the user experience. They'll also be looking to demonstrate benefits that they can then sell. That's when something's coming from an innovator. Then there'll be small-scale pilots, possibly in the real world, but quite a lot with lots of support that you wouldn't get when you launch this thing into the wild, implementation support. Then there'll be larger scale pilots, and I think they are a very, very critical part for us, because as soon as it's then launched into the wild, it's then uncontrolled. Often you have many, many different implementations of this, as many, different, not only the technologies might be different, but they'll be implemented differently in different places. So lots of different roles. To me, I think the key thing is the work that evaluators do needs to be, we're a scarce resource. We need to focus on where we can make the most difference. And that to me means actually looking at what decisions you're affecting, almost having a theory of change for your evaluation. How will you expect the evaluation you do to affect decisions?
Thank you very much. Thanks, both of you. So I think that leads into a question that I've been thinking about from some of the discussions that we've had today, which is around the different stakeholders that are active in thinking about evaluations. The evaluators themselves, there's the commissioners, there's the tech companies, there's potentially a political bent to some of these things too. And what role do you think evaluators specifically can play in trying to meet the needs of those different stakeholders, or say that those needs are potentially misplaced and this is actually what you should be focusing on?
Do you want to go there?
Well, actually, I was thinking of at the workshop, sort of around 11 o'clock, Arnie, where's Arnie? Yeah, there he is. He didn't get to talk about his golden nugget out loud that we came up with on the table. He was talking about an example from the trust where he works, where they were building something and they hadn't really thought about who's going to walk through the door and use it. And Arnie came in and said, who's going to come in and walk through the door and use it? And it comes back to the point about, I don't think we need to necessarily overcomplicate, Fraser said this in that workshop, you don't need to overcomplicate what you are looking at in terms of the statistical analysis. It's that insight of, before you go here, have you got the right data to tell you that this is even a worthwhile thing to do? So there's an example from one of my industry jobs. I worked for Dr. Care Anywhere, which is a competitor to Babylon, actually, and I was head of mental health and long-term condition strategy. And the head of product was telling me a story. She was inducting me to product and all the rest of it. And she told me a story that AXA, who was the main customer, had asked for a sort of health MOT thing to be built. And so they built this thing, they spent a lot of money, literally nobody used it. Literally no one used it. For me, that there's a role for people with evaluation expertise in reframing those problems. So the same thing that Arnie was doing for that group in the trust. It's a really important role. You know what a high quality service that is being used and delivers impact looks like. But it is often difficult for all of those different stakeholders that you talk about, especially as they will have one thing or two things potentially that they are focused on, to understand that within that complex landscape, if you're ignoring this, you've got your mind set on this problem going in that direction, but actually you need to take a step back, understand who's coming through the door, because if your ultimate aim is to improve health outcomes, well, until you solve the problem of who's coming through the door, there's no way you're going to improve the health outcomes with your thing. So that reframing of the problem in a data-led way is absolutely critical, and I think it's a huge role.
I could riff on that, but I'm going to go back to the question and answer it in, just a different perspective, or not a different perspective. But so sort of stakeholders. So I think clearly the people who are making decisions about whether to procure a piece of technology, whether to use it, how to use it, are a key audience for people who are doing evaluation. I think at the moment, what I see is lots of those people in the health systems are not that well equipped to be able to make decisions. So I think to me there's a bit of the role of evaluators and analysts in helping them understand evidence, what good quality evidence looks like. But also I do think there's a role in generally improving kind of data and analytical literacy. Because at the moment, when you're thinking about the information environment, it tends to be dominated by claims from companies wanting to sell their wares, putting forward what might look like to an amateur or someone who's not a professional as being high quality evidence. Actually, it's not very, and it also often is framed in terms of the metrics that they think are important, not the metrics that matter to patients and the health system overall. So I've got one example, which actually someone had put something on LinkedIn a while ago, and then I had a really, really interesting conversation with the founder of the company. So it was about a prediction tool predicting DNAs. And the claim was, our prediction tools are over 90% accurate, and we've saved this many, many thousands of pounds for this one trust. If we rolled it out nationally, we could save 300 million or something like that. So I was kind of like gently inquired about what they'd done. Eventually, they put me in touch with the person who'd done an evaluation, which was not an independent evaluation, and it had flaws in it, although it wasn't terrible either. It just kind of had more omissions. That was the problem, really. But, of course, one of the assumptions there was that every DNA cost money. And, of course, consultants are not sitting around when people turn up. So there was a flaw there. There was also what they hadn't put in there in the kind of claims was about the fact that they'd set up a whole call center. When their algorithm, it was so much more the change than this prediction algorithm. It required a whole change to the pathway in that when the algorithm predicted someone wasn't going to attend, there'd a call center, which would then call them and say, do you know you've got an appointment? So, but what their claims on the surface are, we've saved this number of thousands of pounds, and we've got a 90% success rate of predicting, but they also had quite a lot of false positives as well. So I just think, what's the problem they're trying to solve there? Maybe it wasn't the fact it was a cost problem. Maybe it was the fact it was inconvenience to patients who might turn up for an appointment and because they'd overbooked, they couldn't get to see the appointment. Or maybe it was something else. But I think we need to help people, help rebalance to talk about the problems being solved rather than the actual tools themselves.
Can I give another example? So in some work that we did, it was the 2023 spring budget productivity work, so digital therapeutics in the national channels for mental health and musculoskeletal conditions, with the idea being that those are the two condition areas which are the highest reasons for people to have time off work. Some evidence base around perhaps digital therapeutics, for example, MSK is where we started our discovery work, might be able to address this. And one of the key things we did up front in our sort of pre-discovery work was reframing that problem. So if you think about, a lot of my work, I'm a liaison psychiatrist, which means I work at the intersection between physical health and mental health, and I've done quite a lot of occupational health work specifically. So this is absolutely my bag. And what we know is that Sonia was talking about multi-morbidity this morning in the opening session. I was very, very pleased to hear that. Because this, again, is about the reality of what people experience. They don't experience one condition, they experience multiple, and those are the people who are using services more than others. And we know that that's what's at play when people are taking time off work. So if you've got a productivity agenda, if you're trying to get people back to work, you can try and narrow it down to think, okay, if we give them a physiotherapy app, etc., it might get them back to work. But I know from a clinical perspective, and I was working really closely with the National Clinical Director at the time for musculoskeletal conditions, Andy Bennett, we know from our specialist areas that clinically the complexity of factors at play for somebody are immense. And yes, you can do a lot for somebody, but you have to really understand their experience. And when you are providing something digitally and you've got literally, that's on your phone, in your pocket, that level of interaction is very different to when you're sort of planning services at a macro level. So you have to get this confluence of what we know the evidence base says from all the clinical trials to understanding what is going to make the impact from the individual. And that's literally what we did. So we used what we call a transdisciplinary approach, where we basically looked at the existing academic medicine evidence base. So if you take back pain, for example, we know that people with back pain are less likely to have a relapse if they do several minutes, 50 minutes or so of exercise every day. We know that we know from the psychological and MSK evidence base that what stops people, one of the key factors is fear of pain. So how do you translate that to when we were doing our user-centered design research for that particular piece of work? Well, we mapped that across. We knew that was where that insight from the academic evidence base was, and we knew what we were hearing from the people that we were interviewing, and where we were thinking about how could we put this wrapper, this channel in to get people to this digital therapeutic. And so we knew that was one of the first things we had to address. It's that getting the people through the front door issue. It's not good enough just to stick the thing and make it available. we had to understand what the behavioural motivation for people would be and how to get them there, and to plan our service to actually do that, to plan the whole of that wrapper, and also to think about how are we going to know if this has worked. So we know that there are things that we can look at directly. We worked with all the charities, we worked with all the academics in this space, so we knew what those clinically validated measures we needed to be looking at, and we also developed a strategy for looking at how we wanted to map this over onto the digital metrics that tend to be used, which is that comes from user-centered design and product usage, and starting to marry those together. Funding got withdrawn, so we never got to actually do that, but we do have the strategy there, and we are starting to put that into play with some of the health and growth accelerators work, which is being more regionally led.
It actually sounds like it would be a dream to work with you, Leah, as an evaluator, because actually you've thought all about...
Please someone record that.
About the... Well, you know, having thought, because often, you know, as evaluators, people haven't necessarily thought even about what their... I know it sounds bizarre, but what the actual outcomes are that they want to achieve. You know, as I mentioned, they might think about the metrics which are relevant to their product, but what do we ultimately care about? What are we ultimately trying to do? And sometimes then you're forced into using metrics which aren't really what the point, as we were talking, I think, on our table earlier this morning, aren't really the point of what you're trying to do. They're linked. Someone might think, oh, actually, it's all about emergency admissions. It's nothing to do with emergency admissions, but that's the thing we can measure. And that's the thing that people might want, you know, in Fraser's kind of talk this morning about their optimistic thinking. Well, maybe there's a stretch here, but maybe it could reduce emergency admissions.
I heard someone talking earlier today about understanding the motivation behind each of those data points. And there was work that I did right at the beginning of my career in patient-held records in the Maudsley, where we were working with people with severe mental illness and trying to address things like somebody with a severe mental illness is likely to use 20 years of their life compared to the average person in the population from physical health causes. And so we were working with a group, patient-held record, could do things like mood monitoring, tracking it themselves, Wi-Fi enabled blood pressure monitors, well before virtual wards, agreed, and doing that for themselves, and underpinning it with what we knew from the health psychology, what we knew from supported self-management, which is that you're trying to increase people's agency in managing their conditions, all of their long-term conditions, even in a group that's really quite vulnerable and disadvantaged. And we had a really lovely outcome with a gentleman who had bipolar affective disorder in his 60s, had been detained under the Mental Health Act 3 times. That means he'd been dragged to hospital. So all of his health experience was about being coerced and dragged to hospital. For the first time ever, he saw that his blood pressure was up. He took himself to his GP, he booked an appointment himself at his GP, had his blood pressure managed, 20 years life lost, remember, with physical health causes, and also at the same time showed his GP the mood monitoring that he's done, which showed that his mood was going high, which meant that the GP could order a lithium blood level test at that time. You know, beautiful secondary prevention for me. That's the gold standard. That's where we want to be getting to. And understanding what we were going to want to evaluate in order to know that that's been effective, even when we're preventing outcomes, was really important to being able to put that together in a cohesive way.
So thank you very much for that. And I think one of the things that we touched on earlier in a discussion that we had just before this, Charles, was this idea that new technologies are particularly sort of testing the limits of conventional evaluation approaches, and there's the idea that we need to be a bit more methodologically agile in how we go about thinking about which sort of techniques we use, and maybe learning from one another in a way that is not entirely quantitative, entirely qualitative, but is also using other more creative things. I was talking one of the tables earlier about the idea of using simulation as a means by which to understand whether something is working, particularly at an earlier stage before it reaches patients in real life, in inverted commas. So I wonder if you could reflect on some of your previous experience of working across different evaluation methods, particularly in DHSE.
Yeah, so I think that, you know, one of the challenges for evaluation in this space is this, well, firstly, there's a lot of different products around. There's a massive demand for evaluation, I think. And it also needs to be quite rapid because things are changing so quickly. And I was just reflecting on some of the people I've worked with at NHS England about the things that we used to do, which were about, and it's a bit like what Arno was saying, about almost like pre-screening before the evaluation itself, like, could this work? constructing models for how it would, how many patients would you have to see for this to make a difference? What's the effect size? What needs to be true? And that kind of modelling, that even the discipline of thinking through that, I guess we used to talk about it being like a theory of change, but a much more sophisticated theory of change, where you actually try and put numbers on things and you try and get some of the dynamics of what's in your theory of change into a model. And I think that then just the act of the kind of discipline of doing that forces you to think through, actually, how would it work? Like in my example of the do not attends. Well, hang on, now we need something in that model to field calls. How many people might that be? And sometimes out of that, you can see that it's probably not looking the most promising. It's a bit like what Arno was saying, actually, the question, quite a straightforward, a simple question, the answer to that is, makes you kind of pause and think, well, maybe this couldn't work. So I think, to me, it's kind of what I was saying. I think bringing in different disciplines to think about these things, but starting at before you've done, actually launched this product, into the design of it, it's incredibly helpful to do that, and a good set of tools.
There's something about staging, I think, of the right methodology at the right time, and being a bit more open-minded about how we use that. So I've got sort of two examples in my head. I mean, as you were talking, Charles, I was reminded of some of the kind of product thinking of a similar space. So there is someone called Alberto Savoia, who wrote a book called The Right It, who is a Stanford business professor, has worked with Google, a bunch of other people. And he talks about this, he talks about pretotyping and prototyping. You would all laugh, I think, if you looked at the sort of metrics that he was looking at, because they're super simplistic. So he was literally just talking about setting up something, really just constructing a super simple hypothesis. He talks about having thought about whether the Echo Dot was, voice activated, Alexa type stuff, was going to be useful. And he just got a tin of beans or something, took the label off, and put it down in different rooms in his house, and counted the number of times he had something he wanted to do and that he might want it to be voice activated. So, play Celine Dion or whatever it is. Just literally, and just try to get some data. And there's loads of lovely Stanfordy acronyms like your own data and all this sort of stuff. I really think you'd laugh if you saw it, because it's not sophisticated at all. But that, for me, it was interesting being introduced to that. It was like, well, yeah, that's just like creating a hypothesis, and then thinking about how you're going to evaluate that. That's not simple, but that's not difficult at all. But I think we underestimate how important that is, and then how powerful that can be when you use. We talked about A/B testing in our prep call, didn't we? Where we start to engage with product methods. ASOS know what to show to me at 10 p.m. on a Saturday night in order to make me buy the green skirt that I've been looking at. They know exactly what to show me in order to drive that behaviour. We should be doing that kind of real-time data analysis. There's no reason we shouldn't. And we do have the frameworks to do that. I talk quite a lot in my work about using things like the COM-B model. Don't know if people are familiar with that. Capability, opportunity, and motivations to drive behaviour. Susan Mishi at UCL. And we have really, really elaborated models. In fact, that kind of ASOS stuff, that's like first principles, tiny little bit of marketing psychology. We've got a much more elaborated model of understanding of how we do that. Why aren't we using that to be able to drive better health outcomes?
Yeah. So I think something that's come out of a lot of our discussions, both before and also over the course of today, is how complex things can be. You have a technology that's developed sort of almost in vitro. It's in this testing environment and it works wonderfully, and then it suddenly lands in the maelstrom of the NHS or in the human world. And sometimes that complexity can almost be petrifying. It can cause things to grind up. And in our pre-call, you talked about, Leah, about almost how you can function in the context of uncertainty and in the context of doubt and complexity. You talked about the Cynefin framework. I wondered if you could both expand a little bit about how we can function in this complexity. It's not going to go away.
So, do you want to go first?
Why don't you go first?
Oh. So I'm a psychiatrist. Somebody once said that the motto of the Royal College of Psychiatrists should actually be, it's complex or it's complicated, which I do think I agree with, because we're quite used to sitting with uncertainty. And that, for me, is one of the things that the Cynefin model talks about quite well and gives all of us working in this space a way to deal with that. So those of you who aren't familiar with it, it's David Snowden, organisational psychologist, Welsh organisational psychologist, and information management model, and he's used it working with everyone from military to health, all sorts of people, and internationally. And it's basically 2x2 matrix, talks about information being a kind of simple down in the bottom right, then up to complicated where your relationships are linear. This is where null hypothesis testing is, you know, A, B, and you're putting some parameters around that to test that. And then if you go over into the top left, it's complex, where you have some things that you don't quite know, and you need to leave some room for uncertainty. And then down in the bottom left, where we really don't want to be, but where generative AI will probably put us, is in chaotic, where you've got lots of things that you don't know. My interest is really up in that top left space, the complex, where actually what I've seen in my design training and looking at other industries, everything from as far apart as Formula One car design through to fashion design in my training, they leave those methodologies, those creative industries, leave room for that uncertainty to sit. And you will use things that are called things like design provocations, where it might be something about surfacing some emotion. There was a session earlier today where somebody was talking about how it can be potentially difficult to try and evaluate what an emotional sense is for somebody when they're using a digital technology. Actually, this is something that is quite well known about, and in design research methodology, we have ways of doing that. They just simplify it. They just say, okay, we did some work, for example, at the Royal College of Art with people who have multiple sclerosis. And we were tracking someone's journey who had been in hospital during COVID, and he'd gone from a relapsing and remitting form of MS to a progressive form, so where he was becoming more disabled. And that transition has happened. And he was previously somebody who was fit and well, high-paying job, perfectly able to advocate for himself. Admitted to hospital during COVID. Neurologically, what needed to be done for him was done very quickly within the first couple of weeks of admission, but he then had an extended stay because his functional status had changed. He was now somebody who needed assistive technology, he needed a different living environment, his flat wasn't going to be suitable for him to go back to. And he waited weeks and weeks and weeks for a social assessment, for an occupational therapy assessment, and eventually he was discharged to a hostel, which mostly had people who were IV drug users, and a very difficult environment. There were lots of people, there was lots of crime, lots of difficult things going on, and he became suicidal. When we spoke directly to him, and we were tracking his journey using user-centered design techniques, so qual methods, and we just tracked his emotions. We tracked mood and we tracked agency, and just very simply got him to self-rate and plotted it. And what that allowed us to do was to look at where were the biggest opportunities for change. So in terms of thinking, I'm really interested about where do the innovative ideas come from, how do you create that culture of innovation? And that's exactly what this was doing. It allowed us to see where the biggest opportunity was to change the experience for that particular individual. And focus on, we looked at building sort of a companion thing that looked at, his story was actually that he ended up finding the peer groups, the MS charity peer groups, which helped him understand where in London he needs to bid on housing, that he was going to be more likely to get housing, which got him out of the hospital and into suitable accommodation, which is what transformed the experience for that person. So that join up of what was actually important to that person in terms of their whole health experience. But just using those little metrics, self-rated metrics, was really powerful in us being able to understand what we were going to solution design to help him in a different, and help others in a different situation using his experience. And there's lots of things like this. There's lots of methods that really focus on leaving that space for uncertainty to allow something creative to emerge.
Thank you. Charles.
Yeah, so just adding to the kind of challenges or approaches to looking at complex systems. I guess that really is the space of evaluation, because complicated systems you can generally model. You know, it's like the one about putting the man on the moon. That's a complicated thing, but it's predictable. It's but you can model it, and that's why we managed to we didn't have to have multiple trials of that. We could land a person on the moon in the 60s. But mostly we're dealing with complexity, which is why you need evaluation, because it's unpredictable. We don't really know what's going to happen. We have a theory, but part of evaluation is testing that theory. And I think that, to me, that means actually recognizing there are a bunch of unintended consequences that, and being aware of those and making sure that you're looking at those. So I was thinking about things like, because there's a lot of talk around at the moment about, using AI for note-taking. And the thing people always talk about is it saves time. So all the companies, it saves 4 minutes per consultation. But we know that that's a much more complex system than that. Mostly what doctors are doing when they're note-taking is it's not just recording the information, there's a process of reflection there. So what does it mean for their kind of insights and reflection? Also, when a doctor comes to look back at the notes, does it take longer to read ones which have been transcribed by an AI rather than ones that have written themselves? What does it mean for the interaction between the doctor and the patient? There's a bunch of things which are just showing how it's, we don't know the answers to those things, and that's the role of evaluation, but making sure that we, I guess to me it is about thinking about what are the potential consequences and making sure that we have a way of looking at those as well, studying those as well as the ones which are the obvious ones.
Do you mean things like so what comes into my head with my clinical safety hat on, so I work with the clinical safety team in the NHS app, I sort of immediately, that makes me think of red lines for clinical safety. Those are the things. I want to leave space for uncertainty. I don't want to leave space for uncertainty on that. For me, those are the red lines, and that's where I feel like evaluation has a really important role at that early stage to say, look, you need to leave space to understand what, where the opportunities are, but actually there are certain things, no, you can't.
Well, totally. I mean, and there are a whole load of red lines. I mentioned that, hallucinations, the fact, when you're reading back those things, are you as careful when if you've written it yourself, you might be much more careful, but it's tempting when you're busy to then just say, well, that's fine, that's a good, accurate record. But it might have omitted some really important details, or might have just got something wrong. So yeah, I think you're right.
So hopefully, as you can see, this conversation could go on for a very long time, but I'm conscious we've only got until 20 past, and I want to leave a little bit of time for us to take some questions. We're going to give Slido a go, which is accessed by means of a QR code. Oh, we've got some questions already. Oh, amazing. Well done, everyone. What you've anticipated my intention. If that QR code's not working, oh no, there we go. There was a bigger one, but now it's a smaller one. I might, if we could, just while other people are maybe getting a chance to either upvote or contribute questions to Slido, I might take a question from the room. And do we have a roving mic, or is it? We'll get one in a short while. Is there anyone in the room who'd like to raise their hand? No, I see. Arne, fastest finger. Thank you.
Thanks. I'm Arne Walters, Head of Improvement Analytics in the Mental Health Trust up north. I was going to type on Slido, but it's going to be quite long, so I thought I'll do this. I think something you mentioned, Charles, at the end, it's sort of an example of using AI to take notes. In my mind, there's a very clear example of an innovation being driven by technology and not by need. Because actually, did anyone say that those 4 minutes were the most problematic part of the consultation and that needs to be solved? My guess is no. So I guess be interesting to sort of get your reflections on how we make sure that we use technology to actually address the needs in the system rather than have innovators drive the technology based on the functionality that they've developed.
Oh, that's a really brilliant point, Arne. No, I couldn't agree more with you. And I guess that's where, I talked about the scarce resource of evaluators. And actually, us needing to put that resource where it's not just what we're told are the problems, about we're told what the tools are, it's about what are the problems, where's there's the overlap between the solutions which innovators are offering and the problems that we see as being genuine problems. So I completely agree with you.
Do you have any reflections?
I think What comes out of that for me, Anna, is thinking about that problem reframing and the role of evaluators in being able to help reframe that problem. And it is that piece around, so thinking about that time saved. One of the things we've talked about, I did an AI debate at the Royal College of Physicians a few months ago, and one of the things that we talked about in terms of AI-enabled note-taking was what does that do to training, actually? Is that, there's something about how I'm talking about unintended consequences. And I think, again, leaving that space or planning your evaluation that it allows the richness of those insights to come out is really, really important. And when we were talking about Cynefin model and that complex space, one of the techniques that we use in design research methodology is a sort of probe, test, respond model. And that will be that you design some kind of provocation that you're not quite sure what it's going to throw up, but it might be you take into account the 4 minutes that you think it's going to save, but then you also going to see, oh, hang on, this is going to really impact the training of all the trainee psychiatrists and the trainee surgeons, etc. Is it really worth the risk of that for the benefit of the 4 minutes? And you start to get a richer narrative going around whether this is a worthwhile endeavour.
Thank you. So in the spirit of using Slido, given that we have it working, we should probably take the by far and away most popular question that's up at the top there, which is saying we haven't really talked about ethics of data and AI use. Do either of you have any thoughts or concerns?
Yeah, loads.
Exactly.
This is a
Think
massive
it's a
topic,
priority.
isn't it? You can almost have a whole rapid evaluation conference on this.
You go first, Charles.
I do have lots of concerns. I think probably everyone does about the use of AI, and they span so much, really. So I don't really know where to start, other than that this is just such an important area, and it obviously goes beyond the valuation of a particular product or whatever. There are ethics about, obviously, and how some of the AIs are trained. Is it representative? Are the biases? A whole bunch of issues, really. But I'm not really an expert, other than I know that there are lots of issues.
But there is something, isn't there, about all of us. I'm not an expert either, but I think there's something about all of us being involved in the debate. So there's one of the set texts on my design masters is a book called The Craftsman, which talks about the sort of the core of what you're doing is actually in the actual doing of it, in the making of it. And I would argue we are all the doers. We are making these things. So in the book there's a sort of differentiation, an artificial differentiation between the thinking being done by the artists, whereas somebody who's designing something is doing something different and functional and lower somehow. Whereas actually, no, you are determining what this looks like. And I think when you talk about the ethics of data, I've talked to a few people, I've heard it come up several times today. It's been really interesting conversations around design for, what I think of as design for trust. I was talking to Ellis from the East Hin about design for trust and design for transparency. Again, we know that this is really important. This is what makes your stuff work, and this is what makes it be right for people. It means that we're doing social good, and we have to take into account these social technical constraints and articulate them. And again, I think you all have a huge role in doing that. There's a piece of work by a company called Projects by If. Sarah Gold is the CEO, and I was talking to her last week. And she was talking about her first big job being for DeepMind. And just after they'd had the whole royal-free data usage debacle. And she helped them think about help DeepMind think about this whole issue of data transparency and designing specifically for trust and data transparency. Google it, you'll see she's got some beautiful design patterns. It's really simple things like, well, it seems simple, the design that goes into them is very detailed. But it's like things like, Google Notes will have something that allows you to choose which model you're using to refine your notes, which will build trust. And I can remember being asked a question in NHS England. I was lucky enough to work for a professional designer who'd come from completely outside of health and was just like totally shocked by the way we did things. And he was asking me a question. He said, Leah, I've been asked to look at why people order multiple scans or whatever. And he said, just talk me through what you do. So I'm a neuropsychiatrist, so I have to order brain MRIs and things. And I said, well, I might not order, I might order one because XDGH down the road doesn't have the right size magnet. And so I can't use that data, or I don't know who it's been reported by. That's not somebody who's a specialist in this area, and I know I need it reported by my favourite neuroradiologist down the road at King's, etc. And he went, oh, hang on. You're talking about design for trust. So if you could see the metadata, if you could see that this scan report was done on a 3T scanner and it was reported by whatever and da-da-da-da-da, I went, well, yeah, I might consider not repeating it. I might still repeat it if I didn't like the look of the metadata, but yes, that probably would reduce. And for me, it's those really detailed, this has come back to the Craftsman book I was talking about, it's these really detailed, I think of them as doer conversations that embed these really core principles around design for trust and design for transparency.
Thank you. Any final remarks, Charles? So on that note, in the interest of time, I'm conscious that I don't want to eat into Teresa's time for closing remarks. What I'd like to do is first of all, I'd like to invite you to show your appreciation to Leah and Charles for their fantastic discussion today. And then also, I'd like to say, I know we've only managed to cover 2 questions so far, or two and a bit. But it looks like there's plenty more there. And I think what I'd like to do is take away some of those things, because it really feels like it could be an interesting opportunity for us to think about what is left unanswered from the discussions that we've had today. We can take that forwards. But I'd like to thank you very much. And I'd like to ask Teresa to come up to the stage while we skip off it. Thank you very much.